At this time, I'd like to introduce you to our speaker, Dr. Clint McKinney. Dr. McKinney has worked in healthcare for over 35 years, including 14 years as a rural family physician, practicing the full scope of family medicine. He has both owned a private practice and worked with large healthcare systems. He also worked for 8 years as a national rural healthcare consultant in over 50 rural communities. Dr. McKinney most recently worked as an emergency department physician in rural Minnesota. Dr. McKinney is Clinical Associate Professor in the Department of Health Management and Policy at the University of Iowa's College of Public Health. He is also Deputy Director of the Rural Policy Research Institute, or RUPRI, Center for Rural Health Policy and Analysis. Dr. McKinney has been a member of the RUPRI Health Panel since 1998 and has served on national committees for the Institute of Medicine, the Department of Health and Human Services, the American Academy of Family Physicians, and the American Medical Association. In his capacity as a rural health advocate, Dr. McKinney writes and presents nationally. His professional interests include rural health systems design, healthcare value, physician and administration relationships, physician and hospital payment, and population-based healthcare. Now I'll turn it over to Dr. McKinney.
Thank you, Kim, and welcome all of you to this webinar. We're going to do something I think a little bit different. I was going to talk about physician engagement and value-based care success first, and then if there's time, I'd like to give you a little bit of an update on the quality payment program, which sometimes is known as MACRA. But let's kind of get started here first on physician engagement for value-based care success. As Kim said in my introduction, I'm particularly interested in value-based care arrangements and the physician's role in those. I've also developed a bit of an interest and I suppose an expertise in payment systems, not because I'm really interested in payment, but I am interested in what motivates us to do the right thing or motivates us to do the wrong thing. So finance is certainly one of those, and value-based care includes part of that. So let's get started with that kind of preamble to this. I'd like to start with a story. My story is happened several years ago, and I was having a beer with John Sheehan. Some of you may know John. He is has retired now, but an expert rural healthcare accountant and MBA. And he and I were having a beer and talking about hospital CEOs, kind of like rural accountants and physicians do, I guess. And kind of out of the blue, John says, the hospital CEO's most important job is developing and nurturing good medical staff relationships. And I said, wait a minute, John. What are you kind of delving into this touchy-feely kumbaya stuff for? I thought you're all about numbers. And he said, oh, no, Clint, this is all about numbers. He said, because in my job, I might be able to affect 15% of the operating efficiency or revenue or the expense management of an organization, but it's the physicians and the clinicians with their pens or now their clicks who actually can make or break the hospital finances. So as we move into value-based care, which of course includes not just improving the care, but also doing it more efficiently so costs are lowered, we start moving into an area where one of the truisms of healthcare exists, and that is form follows finance. So in essence, how we deliver care is predicated on or depends on how we're paid for care. And of course, healthcare reform is attempting to change both of those. And I think it's important to understand, as one thinks about healthcare reform, fundamentally, what healthcare reform and more specifically payment reform is doing is transferring financial risk from payers to providers. So providers being hospitals, physicians, other clinicians, healthcare organizations. And this is indeed the volume to value transition that is spoke of so frequently. Just to give you a sense about this payer risk continuum, this transfer of moving from the left to the right, I did put together this graphic that shows us all the way to the left with relatively high payer risk, and that's the fee-for-service model. And that includes, by the way, cost-based reimbursement in critical access hospitals and prospective payment system in the larger hospitals. And then if we move a little bit more to the right, we start moving into the pay for performance or value-based purchasing arena, a little bit more to the right, a little bit more provider risk in shared savings. This is what Pat Skoush talked about yesterday last week with accountable care organizations. And then bundle payments, and then global budgets, which we're seeing, and I'll mention a little bit later, we're seeing in Maryland and now increasingly in Pennsylvania, until we get to kind of the total cost of care, which there's no system right now doing that, although the Accountable Communities for Health and some of the SIN grants are trying to work in that direction. So what this requires, this movement from the left to the right, it requires that we as healthcare organizations start learning how to manage financial risk. So I put up a definition here for you about financial risk management. That's the opportunity for revenue gain and or the risk for revenue loss based on non-financial organizational performance. And there's some examples there that some of you are familiar with. I actually had them in the graphic before. And again, moving a little bit from the top, which is more to the left, or more payer risk, to the bottom, which is more provider risk. Now, I've been asked in the past, well, what actually is a value-based payment? Well, even though it can get complicated, and who knew that healthcare would be so complicated, a value-based payment is payment for one or more parts of the triple aim, or the three-part aim, as CMS refers to it, and that's, of course, better patient care, smarter spending, and improved community health. It's not a payment for a unit of delivered service or care. Therefore, it's not fee-for-service. It's not cost-based reimbursement. I'd argue it's not prospective payment either. And I think, as probably most of us on this webinar know, it is coming to rural. It is. And if that's the case, those of you who are hospital administrators know that you'll need your docs along with. I'll kind of describe some of the situations where that's the case. So I want to argue that physicians are critical for value-based care success. Value-based care requires those who are on the sharp end of care, those who are on the front lines. And who better than they, physicians, nurses, therapists, who better than they to design the care processes that they will use, interact with patients on a daily basis, one-to-one? Who better than they to either follow the guidelines because they're well-known and they're science-based, or not follow the guidelines? And for those of you who are interested in resource use efficiency, it is they, just as John Sheehan said, who are the ones who are going to use your precious resources most efficiently. And then, pretty important here, it is going to be the physicians and, more broadly, the clinicians who are going to achieve the quality and efficiency that's necessary to realize a value-based payment. And, of course, that's what we're all interested in. If we're going to be investing in our time, our human resources, our financial resources into developing the care processes to deliver value-based care, we want some assurance that we're going to receive value-based payment for those efforts and those investments. Now, these value-based care processes to receive a value-based care payment is most likely to be successful when rural hospitals or physicians are working together, not at odds or not against one another. And to exemplify that just a little bit, I'd like to discuss three different, pretty common now, value-based care initiatives. These are all through CMMI. But let's just talk about them for just a little bit. Well, probably most of you are increasingly familiar with shared savings plans or accountable care organizations. So in this situation, which is probably the most prevalent value-based care program for us in rural America, in this particular case, as Pat talked about last week, savings, if there is any, based on a predetermined budget, are shared with the accountable care organization. Now, it's essential that physicians are at the table and present to realize those shared savings. Recall with the accountable care organizations, at least in the Medicare shared savings program, these are outpatient care performances that are being evaluated. Outside of the hospital, outpatient care, there's 31 performance measures, so the traditional hospital really won't impact these. So we do need to have our physicians or our other clinicians working with us. You'll notice that even from the beginning of the shared savings program, patients have been attributed to the accountable care organization through primary care visits. So again, if we want to grow our accountable care organization as a rural hospital, well then we need quality primary care physicians that attract patients to themselves and thus to our accountable care organization. Increasingly, and these are new changes that are just happening in the Medicare Shared Savings Program, patients now may increasingly be able to choose their ACO. So this is going to require, for success, local hospital utilization, because every time a patient is sent away from your hospital, you lose control of that patient, and for those of you who are the accountants on the call, you're not able to utilize your fixed costs if patients are moved out. So we need that local hospital utilization by the ACO, and we need trustworthy negotiation between the two parties, between physicians and hospital if they're both members of the ACO. So therefore, physicians are essential to the success of an accountable care organization. Let's try another one. How about episode-based payment initiatives, or what Medicare calls these bundled payment care initiatives? So this is where the hospital and physician payments are bundled together. They're one for an episode of care, like hip replacements, or a heart attack, or even a colonoscopy. And there's a whole variety of them that physicians, hospitals, health systems are starting to engage in. Interestingly, this isn't as common for us in rural, but it's quite common elsewhere in the country. So the organizations that make bundled payments work well understand that physicians are essential to realize costs less than payment. And in a bundled payment, that's the success story. You have to spend less money than you're getting paid, and suddenly the bundled payment initiatives becomes profitable for you. So what we need out of physicians and other clinicians, we need an efficient care delivery system. Who better to design that than the physicians? We need team development. You can't do this alone. The payment system requires bundling together the payments, thus you need to bundle together the care processes. So we need to develop a team to be able to deliver these care. We need to coordinate care amongst us, and once again, you're seeing the repeat come up again. We need to use our local hospital, in this case. Every time we send the patient out of our bundled payment, we're losing control and losing that money. And we need trustworthy negotiation between these two parties. And admittedly, it's more than just two parties, but for argument's sake, between the hospital and between the physicians. Let's do one more. So global hospital budgets. This is the really kind of hot topic right now. And let me give you a little bit of background on this one before I kind of launch into the physician part of this. Right now, global payment is up and running in Maryland. And in this particular case, in Maryland, what happens is the hospital is paid a per capita payment to care for the patients attributed to them for an entire year. So imagine, and I'm simplifying for the sake of discussion, but imagine you are now a hospital administrator whose financial success has been for your entire career, has been maximizing patients in beds, maximizing the use of your imaging equipment, maximizing the use of your lab equipment, maximizing the use of your income-generating personnel through fee-for-service. Flip that on its head. Flip that operational challenge on its head to now say, how do I keep my community healthy? How do I keep people from coming to my emergency department? How do I keep people from needing admissions? How do I now prevent those primary ambulatory care conditions that can be prevented? How do I direct patients to primary care? How do I do all that now with this new payment model? Pennsylvania is following along. Their program just started January 1st of this year, And I'm working with Pennsylvania quite closely in their program, a little bit different, where their payments are not capitated, but instead what they're still receiving, they're receiving a bucket of money at the beginning of the year or over separate time frames throughout the year that represents what the revenue had been adjusted some for inflation and other factors in the previous year. So once again, the operational challenge remains. Again, imagine thinking about optimizing your service lines to optimize revenue, and now what we want to optimize is health and avoidance of healthcare services to be financially stable. So physicians are essential to this. They're critical to this because we need to realize now we want costs less than our budget. So if we have a budget at the beginning of the year, we must spend less through the upcoming year to realize a profit. So we need new community care teams. Who better than that? The people that actually interact with the community. We need new community relationships. We definitely need care coordination. And when patients do need hospitalization, we want them hospitalized locally. Again, once they leave our area, we're losing control of that service. And we're paying for that as well, too. And then lastly, again, it's a repeat, we need trustworthy negotiations between the hospitals and physicians. So what's the challenge is that we need to have hospitals, physicians, health systems working together. So what's the solution to that in value-based care? Well, I'm going to argue, along with Jean-Luc Picard, that engagement is what's really key. Now, physician engagement, if you look back through the literature, and I'm using physicians here because that's the way the literature speaks about physician engagement, though I would argue that all clinicians is really appropriate here. But this has been a pervasive and persistent challenge for probably decades. For as long as CEOs of hospitals have been asked what keeps them awake at night, physician relationships seems to bubble up to the top. And I'm going to argue that now more than ever, this importance of physician engagement is critically important because of this transfer of financial risk that's happening in our payment system. We must be able to work together to be able to optimize value-based care to receive value-based payment. So sometimes it's helpful to maybe throw a definition out there for you. So I want to talk about physician engagement as meaningful, So physician engagement is this. It's proactive physician involvement and meaningful physician influence that lead the organization toward a shared vision and a successful future. And as you can see on the slide, I've underscored proactive and meaningful. Proactive means this does not happen by guess and by golly. It does not happen with a friendly handshake. It needs to be proactive, and we'll talk about that in just a little bit. And it needs to be meaningful. It can't be that physicians are invited to the table after a decision is made, for example. Now, physician engagement, as I kind of define it there, is really a cultural phenomenon. That is, how does our organization and its leaders behave? Especially, how do they behave when no one is looking? That's probably a definition of culture. But I'd also argue that physician engagement is both observable, it's measurable, and it's improvable as well, too. But it is challenging. It is. Why is this so darn challenging? It's been a persistent challenge for us over several decades. Well, I'd argue that one of the ways is that there's unrealistic expectations. You know, every time I think, you think to yourself that I need to go out and change that person. You're going to be frustrated, disappointed, if not angry, maybe at yourself and maybe at the person you're trying to change. So it's an unrealistic expectation to try to change others. Instead, what we really want to do is we want to change our approach to others. Next, even though it's a bit of stereotyping, and stereotypings are automatically suspect, so I want you to forgive me, physicians are not the same as administrators. They're inculcated differently. They're socialized differently. And they have different personalities. Now again, bear with me please. Forgive me please. That's a stereotype, but it may be important as you start to work with physicians. We'll come back to that. No action plan. I'm a believer in action plans. There's no measurement. There's no follow-up. And I'll tell you what, this just gets tough. And you start to move on to things where you can kind of see movement and see successes a little bit more easily. But I'd argue that's a mistake. This is really important, and it's important especially in our value-based care world in which we're moving. So let me talk about this unrealistic expectations a little bit more. Again, as I said before, it's hard to change others, and it's easier to change your approach to others. We have this kind of sense of this is the way expectations should go. We implement a plan, expect it to go that way. But the reality is, especially with physicians, it's just going to be all over the place. But please remember, as you lead your healthcare organizations, and you all know this, that leadership is people following you because they want to, not because they have to. I worked in a hospital not that many years ago, and I was about physician engagement. I was talking with them about physician engagement, and I kind of opened up my conversation with the CEO, and I was just kind of doing small talk, and asking, well, what do you think about physician engagement? And almost verbatim, the hospital CEO said to me, he said, the physicians see who signs their paycheck. They'll do what I say. And I paused. I didn't say anything, but I realized I'm going to have my work cut out for me. So I think it's better that we consider physicians and maybe most of our staff as volunteers. They have other job opportunities. They can leave. They can retire. So if we treat them as volunteers, might that be a better way to think about them rather than employees? And as you start to develop these relationships that allow you to engage physicians, remember, it's all about, and it's always about, trust. Relationships built on trust. So let me move a little bit to those differences that I was describing before. And I'm going to say it again. I probably said it 3 times, but this is stereotyping. But this is still really important. And if you could kind of keep this slide out and kind of refer to this as you either, 1, start to engage physicians, or number 2, get frustrated by trying to engage physicians, please kind of keep some of these differences in mind, if you will. And I won't go through all of them, but let me just kind of pick out a couple. Physicians are expert at working one-on-one with a patient. They are doers. They understand a problem, design a solution, and implement every 10 minutes. Now, you all who understand how personalities, relationships, processes, structures work in a complex organization like a hospital, probably one of the most complex organizations ever, understand that doesn't work. It doesn't work. But then, so you ask a physician to do something that's not solution-oriented, it's process-oriented. It's not that he or she is unable, but now it becomes work. It becomes work. Physicians tend to identify with their profession as opposed to their organization. I challenge you sometime. The next time you're at a social event, watch a physician introduce herself. She'll say, hi, I'm Dr. Joan. I am a family physician. And then watch the CEO. Hi, I'm Bill. I'm CEO of ABC Hospital. Do you see the difference? It's critical. And the reason why it's critical is that when you ask a physician to actually start advocating for an organization as opposed to her profession, it's not that she's unable to do so. It just becomes work now. It becomes work. So please, if you would, keep this slide in mind as you're engaging physicians. It may start to explain some of the frustrations that go on and help you think of creative ways to kind of move beyond this. Here's another list. This comes from the RAND Corporation from about 5 years ago. And I think it's an important list when you start thinking about one of the most important change processes around, which is understanding what's in it for them. So understanding what's in it for them. I won't list all or read all of these, but it is important to physicians that they have an organization in which is delivering high quality, and they're encouraged to provide high quality. Everybody talks about the burdens of electronic health records. One of the ways that you will make points with your physicians is first acknowledge their frustrations and their challenges around the burden, around time, around interfering with face-to-face encounters, and help to overcome that. They're looking for collegiality and fairness in the workplace. They're looking for income stability, and they also, again, require help with the rules and regulations burden. So keep these in mind. Again, I'm not going to read all of them. Keep them in mind as you think about how can I best engage physicians. Now, what's the process? I'm going to come back to this, what I said earlier. First of all, recall the conversation with John Sheehan. I'm a firm believer that this is a CEO responsibility. This should not be abdicated to others in the group, in the leadership team. This is the CEO's most important job. You'll see CEOs concentrate on a building project, or they may concentrate on board education or board relationships, but I'm not sure there's anything that much more important than developing a plan for clinician engagement in your organization. As I said, I'm a believer in action plans. I believe that an action plan should have accountabilities. It should allocate resources. It should have due dates, and it should have measures. I've probably worked in 70 different rural hospitals, and I'm still waiting for the time. And if any of you on the call have this, please send it to me. I'm waiting for the time that the hospital CEO pulls out of her desk drawer, her action plan with Gantt chart, accountabilities, resource allocations, measurements for physician engagement. So if you have that, please send it my way. I'd be very interested to learn from it. Now, I mentioned measures at the very bottom, and action plans require measurement. Well, here's something to get you started. This is not exhaustive, but I'm going to argue that if we look at how physicians are engaged in governance of our organization, that's a measure of physician engagement. How are we educating them, not clinically now, not clinical education, but educating them about the nuances of decision-making in a complex healthcare organization? What data are we providing them? What data are we providing to help them make wise decisions, again, in addition to clinically, but also efficiency as well, too? And then how are we compensating our physicians? Are we compensating them in ways that reflect what we say is important to our organization? When people often ask me, so what specific steps do you recommend for physician engagement? I could probably come up with 20 or 30. And 20 or 30, people's eyes glaze over, as I'm sure mine would if somebody told me that. So I'm going to boil these down to 5 strategies for success that I think are important. And you all may find others that are important. That's okay. But this is something that I'm going to suggest. I think it's important that you find mutual interest with physicians. Find a shared vision. Find shared goals. Understanding that dichotomy of physicians and administrators may make that challenging, but it's certainly not impossible. Next, reduce meetings. Physicians hate meetings. We all know work gets done in meetings, but it doesn't feel that way to a physician. At best, he or she may feel like I'm just not accomplishing anything here important, or worse than that, he may be taken away from productivity in his office or in the hospital. So reduce meetings. Think about carefully, is a meeting necessary? Is there a way to convey information or make decisions in a less intrusive way? Listen intentionally. Listen intentionally. To be honest with you, I just can't stand when I hear a hospital leader say, I've got an open door policy. That's not listening intentionally. Instead, I'd prefer, you know what, I just kind of catch my physician in the hall every once in a while when they're not busy and say, is there anything really bugging you these days that gets in the way of doing your job or getting home at a reasonable hour that I could help with? That's listening more intentionally. So communication should be 2 ways. It should be 2 ways. It should be conveying information. It should be listening intentionally. Think strategically about how, what, and where of data you present to the physicians. I always kind of joke, never put a spreadsheet up on a PowerPoint slide. Maybe keep the spreadsheet in your back pocket so you can explain the data. But what ideally you want with presenting data to a physician would be that the physician understands the data within about 10 seconds of looking at your chart. And then about 10 seconds after that, she understands how to change her practice to make the data, to improve the data in a positive way. So think strategically about data. It's very easy to get data overloaded with all the measures we're tracking, and everybody understands this. Even organizations that do measurement of clinical quality, for example, understand the importance of harmonizing their data measurement. So I'd ask you to participate in that endeavor by thinking strategically about what data should be presented, how it should be presented, and when it should be presented. And my last one is a plea to always, always follow up. If you explicitly or even implicitly suggest an outcome or something you're going to do, please do it. Physicians are like elephants. They just never forget. And the quickest way to destroy trust in a relationship is to not follow up as you promised. So always, always follow up. I think it's important for us to sit back periodically when we kind of think about our relationships between physicians and hospitals or health systems, that we start thinking a little bit about how is our relationship perceived by those that we have pledged to serve. And of course, that's our rural communities. Physicians and rural hospitals are a historic partnership. They are a historic partnership. We together are the face of rural healthcare. And when we're not together, that face is not as pretty. It's not as welcoming as it could be. Our communities, our patients are smart. If they see strife among our physician-hospital relationships, if they see us marching off in different directions, they're much less likely to support us during our organizational times of need. We are an urban alternative, and I argue that we are a strong urban alternative, but we are stronger when we are together, moving in the same direction. Value-based care is going to require a new skill set. I already mentioned the hospital operational skill set if you were to move into a global budget. But we're also the conveners in our organization, and conveners in our community, excuse me. For better or for worse, we are the locus of resources. We are the locus of human capital. We are the locus of financial resources, some more than others. And believe it or not, we are the locus of value-based care conversations. This conversation is starting in hospitals and physician practices much more so than it is in some of our social services organizations, even though their mission will benefit from it. So we do have a community focus, and we do have an opportunity to be conveners in our communities, which will increasingly be important as we deliver value-based care. We're also the economic engines in our communities. Boy, if we put together the healthcare system in a community, if we were to include physician practices, hospital, outpatient services at or through the hospital, long-term social and services and social support systems, if we were to add all of that together, we can't help but be probably the #1 employer and economic engine in our community. That has value. And lastly, there's something that has great value, but I don't quite know how to monetize it. And that is that the presence of a strong marching forward together local healthcare system provides a community a sense of safety and security. And I just don't think that can be underappreciated. So I'd like to end this part of the webinar with just an encouragement to engage physicians. I've talked to way too many CEOs that have expressed their frustrations, discouragement, anger at the job of physician engagement. It's tough. It's tough, and we do need to manage expectations around it. But also, in the words of one hospital CEO that I worked with here in Minnesota, when I asked about physician engagement, and he said, you know, Clint, I'm blessed by my physicians. And you know what? I don't even care if he's lying to me. But the fact was that he's putting a face on the importance of working together. And I think physicians can be astonishing allies. And as I said before, please remember this starts and ends with relationships built on trust. Trust that engages the mind, truth that engages the heart, and teamwork, which realizes the vision of sound community health and well-being. Here's some additional resources for you as well, too, if you want to take a look through these. In particular, Michael Kurtz, that dual role dilemma, where I kind of developed that one slide, I think it's slide 15, that I feel is so important. So with that, if I could, I'll switch gears for you, and we'll switch gears a little bit just to give you a quick update regarding QPP, and with that, we can answer some questions. So we'll take a moment here. We'll get, here we go, going to get caught up there. So I just want to give you a little bit of an update around the quality payment program. This is a really good example of where I kind of said before with my background that Kim gave. It's not that I'm so interested in payment systems, but I am pretty interested in how they motivate us to do the right thing or the wrong thing. And whether you like or you can't stand the quality payment program, it is a movement by CMS and Medicare to start rewarding physicians differentially, and differentially based on a really complex system. But I'm going to argue that it's a step in the right direction, even though maybe it may be sideways sometimes, but it's still a step in the right direction to rewarding physicians for performance we all know is important. So let me just kind of start off with this. Just as a reminder to you, the Medicare Access and Children's Health Insurance Program Reauthorization Act, also known as MACRA, was a 2015 bipartisan law. And this is a time, which is still going on right now, where Congress can't agree on anything. But they did for MACRA. And it replaced these things you're seeing right below. What we in healthcare seem to kind of concentrate most on around MACRA is what's called the Quality Payment Program. And the goal of the Quality Payment Program, or I'm abbreviating as QPP, is to improve health outcomes, promote smarter spending, minimize burden of participation, that's questionable, and provide fairness and transparency in operations. So that's the party line, and you can argue whether we're getting there or not, but that's certainly the party line for the QPP program from CMS. But I think what's important here, for those of you who manage physician practices, this is the first time in just about a decade that there's been at least a significant opportunity for physicians' pay increase. We have not had this before, so this is relatively new. So as you may know, QPP is a physician payment incentive system or disincentive system based on two different pathways. One is the merit-based incentive payment system, or MIPS, and then I'll talk about the other one here in just a second. But MIPS is a bonus and penalty calculation that's based on 4 different factors or categories of factors with quite a few metrics within each of these. And they are reducing cost, improving the practice, improving quality, or advancing care information. And advancing care information is kind of the old EHR, meaningful use kind of thing. Quality, or just like you would expect, is improving quality from everything from diabetes to congestive heart failure care. Practice improvements is a new one where they actually do highlight opportunities where practices might do something that doesn't generate income right away, but it's good for the community, like setting up vaccine registries, for example, working with EMS, for example. And then cost is just reducing cost. There's no reporting for that, and that's probably the most problematic part of the MIPS system, or the merit-based incentive payment system. Now, what's important here is this maximum bonus and penalty, and I kind of stole this from the advisory board with citation below. But the key with this is I want you to take a look for a moment at the spread here for potential. Potential of a 9% penalty versus a 36% bonus. Now, I'm thinking as time goes by, the bonus is going to be less likely here, but just for the sake of argument, and I want you to do a thought experiment for those of you who are kind of managed practices or those of you who own practices. Imagine that you have a new family physician on your staff, and she is all about quality, and she is all about patient satisfaction and trying new things. And by the way, she knows finance really, really well. And she has it in her head that she is going to smoke at doing MIPS. And indeed she does. And she maybe qualifies for the big bonus, so she gets a significant increase in her Medicare reimbursement based on her performance. And then your other doctor down the hall is this gray-haired curmudgeon, that would be kind of like I am, down the hall that says something like, I'm not going to do that damn government program. I don't care about this. I've been doing this for 30 years. I know what I'm doing. And he gets a 9% penalty. And somehow he gets wind that the woman down the hall is making 40% more than he is on her Medicare visits. And he comes storming into your office and says, what's with this? So now I think that scenario is very unlikely to happen. Practices are much more in lockstep with each other. But just imagine if it did. And imagine the managerial challenge you will have with this. But instead with the argument is, let's engage physicians so they're all just like that young woman physician I was describing, who want to really do well at MIPS. Alternate to the MIPS is the Advanced Alternative Payment Model. Now, this is an automatic 5% bonus with no risk for penalty. That's just given to the physicians, 5%. But for the physician to be able to qualify this, they must bear financial risk. So that's a risk for monetary gain or loss in some sort of model. For example, right now, this includes the risk-bearing Medicare Shared Savings Program, ACOs. That's Track 1 Plus for now, until the change now. But previously, it was Track 1 Plus, 2, 3, and the last one, Pioneer. God, blanking on Pioneer. There's certain bundle payment models where this works, and then also the Comprehensive Primary Care Plus model, CPC Plus model, that's being piloted in various places around the country. So you have to be kind of in those to be able to get that 5% bonus if you want to do that. But the key here is that this is a new reality. Kind of the dirty little secret that we don't hear about with QPP is that along with QPP is the actual payment for physicians is only 0.5% for 5 years, and that just goes through this year. And then 2020 through 2024, those 5 years, there's a 0% increase in the physician fee schedule. So even though I said this is an opportunity for pay increase, you're not going to do it by not participating. You won't. You'll actually get a payment reduction if we have figure inflation in this as well too. So I said that this is the MIPS bonus and penalty, or the 5% alternative advanced payment model bonus. And again, for those of you who are leaders and managers, think about how you might manage this disparity in your clinics, and how instead might we engage physicians to be successful in the QPP. Now, I've got some new information here for you that this is not yet released because our paper around this is just kind of under review right now. But I can still tell you what the data are showing. So at the Rupert Center, we've been analyzing participation in the quality payment program. And we found that about 10% of primary care providers around the country are participating in an advanced alternative payment model. By primary care providers, what I'm referring to here is family physicians, general internists, general pediatricians, geriatricians, advanced nurse practitioners, physician assistants. I think that's all of the list in this, but they're primary care providers. But only about 10% are participating in an advanced alternative payment model. Less than 30% of PCPs are participating in MIPS. So what that turns out is almost 60% of primary care providers are exempt from MIPS or not in an AAPM. So that's significant. When we have only 40% of primary care providers actually participating in this program, which is designed to reward us for good practice behavior, either around EHRs, either around clinical quality, and around cost control and practice improvements. It got a little funky here in our conversion to PDF, but you can see here that metropolitan PCPs slightly more likely to participate in alternative payment models, advanced payment models. That tells me that those models are likely more available to metropolitan physicians, which I think is wrong. Metropolitan physicians slightly less likely to participate in MIPS, probably because they're participating in advanced alternative payment models, but they're exempt from MIPS at about the same rate. About the same rate. And speaking of that exemption from MIPS, this is kind of what happened. And those changes I was just describing were 2017. So these are 2018-19 changes. So when I'm reporting these data here, I'm not even considering the changes that are going to be happening 2018-2019. So you probably all know that practices with certain volume thresholds were exempt from MIPS. That used to be $30,000 or 200 beneficiaries. That's now raised to $90,000 and 200 beneficiaries. You can now form virtual groups, including 1 to 10 MIPS eligible providers. You can do that. The quality category, the proportion of quality measures that make up your penalty or your bonus was increased to 45%. Remaining 55% are now related to cost, practice improvement, and electronic health record or care information. And then the cost category is increased to 15% as too, which I continue to think is somewhat problematic in these calculations, but that was increased to 15%. For those of us in small practice, there's also a bonus added for being in a small practice. But that bonus is added to the quality category. And remember, if you saw in the third bullet, that quality category only represents 45% of the weight. So those of you who can do the 6%, 6 points out of 100, 6 points times 45%, we're really only getting a little bit less than 3 points total to our final score in this particular scoring metric. So those are some significant changes, selected ones. There's more, but they're selected ones just kind of for your information. I want to, as my last slide, I think, I want to give you this. These are our partners in spreading innovation around the country. You'll see the Rural Health Value Project, through which I'm very active. Of course, Rural Policy Research Institute as well, too, as per Kim's introduction. And, of course, Kim's National Health Resource Center, Sally Buck, Terry Hill, and all. RHI Hub, which is just for those of you not used RHI Hub for almost anything rural health related information resource, you should. And of course, National Rural Health Association and American Hospital Association, all very important resources and collaborations to spread innovation. So that is the end of my slides. I am happy to try and answer some questions if you'd like.
Thank you so much, Clint. If anyone has any questions and they're called into the phone line, you can press *2 to unmute and just begin speaking. As we wait for anyone to speak up, there were a couple comments during the presentation, Clint. John says, in a very rural, underserved area in the Alabama Black Belt, historically we have had persistent poverty and a shortage of medical services. Our small hospital, 20 beds, has a nursing home and physician's clinic. The payment model is not going to work for us until we relieve all the problems that poverty has created over generations.
Well, thank you, John. We all understand, I would like to think, how poverty, housing inadequacy, food scarcity, poor water quality, poor air quality impact health. And I've just kind of written a paper, or at least introduction to a paper, talking about how those social determinants of health directly impact the viability of hospitals. They go hand in hand. Now, admittedly, there are lots of other reasons that make the viability of hospitals and their ability to participate in value-based programs make it difficult for that. There's lots more than just the social determinants of health, but it's certainly an important one. Unfortunately, we by ourselves are not going to fix poverty. But I would argue that by not participating in value-based care programs and relying on fee-for-service in hospitals and in physicians, we will see a continual denigration of our bottom line. Now, I'm not sure what your bottom line is, John, but I work with a lot of hospitals that are just barely breaking even on their total margin and are way below zero on their operating margins. So in Pennsylvania, the global budget in Pennsylvania for some hospitals has been a life ring. So imagine if you were protected against fee-for-service changes, fee-for-service drops in fee-for-service payments and drops in volume. So if you were protected by that, would that help your financial outlook, or would it hurt your financial outlook? A lot of hospitals in Pennsylvania and in Maryland are saying it's helping. It doesn't fix things. If you have a minus 10% operating margin and you can move it up to negative 5% operating margin, it's still bad, but it's better. It's better. So I'm hoping, John, you do find ways to make these new payment systems work for you and work for your community.
Thank you, Clint, and thanks, John, for that comment. Clint, are SQHCs disallowed from QPP?
Yeah, I think, there has been a lot of talk about that, and I would have to go back and check the regulations, but I think they are because they're paid differently with the prospective payment system. It's paid differently than the Medicare or the Medicare physician fee schedule. Does anyone else on the call know that one for sure?
Kimberly, we can get an answer for you and send that to you via email as well.
You bet.
Are there any other questions today for Clint or comments? Hello?
Yeah, I guess we don't have any other questions, I suppose.
Oh, I'm sorry about that. I was actually speaking on mute. I just was thanking you, Clint, for today's webinar and for sharing some great strategies and suggestions. It's clear that we need to begin communicating differently with our physicians in order to be successful in these value-based models and the new quality payment program. Do you have any closing comments, Clint?
I don't. I would encourage you to not be discouraged by the challenges of physician engagement. It's important. And it's important as we move away from fee-for-service into value-based care payment and delivery systems that require us to be a team for our communities rather than disparate groups. So it's tough work, but I'm not sure there's anything much more important. So stay at it, keep the faith, keep your eye on the prize, and I think you'll be rewarded with successes for both your community and your organization. Thanks very much for allowing me to participate, Kim.
Absolutely. Thank you, Clint. Everyone, before you log off, please answer the 2 poll questions up on the screen. The recording of this webinar, along with the slides, will be available on our Help Webinar Playbacks page today. At this time, I ask that you complete the short online assessment for this webinar. Use the links on the screen to access our large array of